Welcome to our California Thoracic Society Friday evening educational webinar series. Tonight's presentation was developed by the California Thoracic Society in collaboration with GSK. Today's presentation is titled Understanding the Pathophysiology and Burden of COPD with Blood Eosinophils as a Marker of T2 Inflammation. Is it the time for precision medicine in COPD? Tonight's esteemed speaker is Dr. Hanania. He is the Baylor College of Medicine, Professor of Pulmonary Medicine, Director, Airways Clinical Research Center, and Section Chief of the PCCM Ben Taub Hospital. At the end of our presentation, there will be an opportunity for live Q&A. Please send some questions in to Dr. Hanania and use the Zoom Q&A functionality to do so. You're welcome to submit questions anytime during the presentation, and we'll answer all of them at the end. I now turn it over to Dr. Hanania.
Thank you so much, Jason, and thank you for CTS for inviting me and for GSK for supporting this presentation. It's a pleasure to be here and spending some of time of my Friday evening with you, discussing a very important topic that's an emerging topic in COPD and focusing on the understanding of what we know about COPD now compared to what we used to know many years ago. And as you know, this is an old disease, but we have a new look at this old disease, not only a new look at its pathophysiology, which is what we're going to focus on today, but also a new look at its clinical presentation, risk factors, in course, and of course, treatment. I'm going to focus on a few things today, mainly three major aspects. One is the burden of COPD. Most of you are in pulmonary medicine, so you understand this is an impactful disease, still the third leading cause of death around the United States. We'll talk about the impact of COPD, but more in depth about the impact of the exacerbations that occur in COPD. And why are they important, and why is it important to identify patients at risk of exacerbation? We're going to dig deep into the pathophysiologic changes or mechanisms of this disease, what we have learned about this disease, from what we used to know about the pink puffer and blue bloater to now the multiple phenotypes and multiple even endotypes and the different mechanisms of the disease. And then finally, the last but not the least, we're going to start discussing why is that important for a clinician like myself. I do clinical trials in COPD and asthma, but also I'm a clinician educator and I treat patients with severe COPD. Why is it important to understand these new changes in this disease or new things that we discovered about this disease? And how can we, in the era of precision medicine, utilize some of this in selecting appropriate treatment for the appropriate patients? It is no longer accepted that we approach this disease as a one-size-fits-all, and we're going to talk about what I mean in the next few slides. So first, let's understand the impact of COPD. As you all know, this is a very old disease, but it is still haunting us as clinicians, but also haunting our patients, the healthcare system, and not only in the United States, but throughout the world. There are several consequences of this disease, and of course, exacerbations, we're going to talk about those in a minute, can lead to disease progression and worsening lung function. So we know that COPD obviously is a disease of the airway. In fact, when you look at the definition of COPD by Gold recently, they mentioned that COPD is a heterogeneous disease that affects the airway, causing fixed airway obstruction that is usually progressive, that is characterized by airway inflammation. But in the newest definition of COPD, they actually removed the risk factor, which is smoking. Majority of patients with COPD smoke, but they purposefully removed that risk factor because there are non-smokers with COPD, and actually that number may different between countries, maybe around 30 to 40% of patients don't smoke. And indeed, Gold now has redefined what we call the etiotype of COPD, the risk factors, into several categories, including the risk factors of poor lung growth, exposures, obviously, smoking is very important, infections early on in childhood or later on, like TB can predispose COPD. So there are different, and of course, genetic is very important. And there is an overlap with asthma as well. As you know, as you see on this slide, in general, we know that pathophysiologically, this disease affects the small airway with small airway inflammation, mucus plugging, airway narrowing, but also destruction of the lung and the alveoli, like we see in emphysema. And we know that exacerbation are very common in patients with COPD. The more severe the patient has, it's COPD the patient has, the higher risk of exacerbation. And you can see the numbers from 2 to 3 exacerbations per year in general. Now, not all patients with COPD do have exacerbations, but there is this, what we call the frequent exacerbator phenotype, those patients who have 2 or more exacerbation. Those are very high risk of subsequent exacerbation. And of course, all this adds to the human cost, but also to the cost of the healthcare system. It's estimated that in 2038, we will be spending about $57 billion in the US on COPD. Of course, most of these costs come from what we call direct costs, driven by exacerbation and hospital admission. We know that this is a spiral down. Unfortunately, it's a progressive disease, and most patients end up having symptoms early on exercise, but later progress to symptoms at rest. And of course, during the course of the disease, exacerbations can lead to significant lung function decline. Post-exacerbation lung function usually does not recover to the baseline lung function, and rate of severe exacerbation needing hospital admission increases with every severe exacerbation, as I'll show you in a minute. And patients with frequent exacerbations, they have worse decline in not only lung function, but quality of life and increased risk of mortality and increased risk of airway inflammation. These are some data from a large study. It's an epidemiologic studies, but also collected from other studies that have been published since then. But Sami Suisa in Canada many years ago, looked at a cohort of patients with COPD who have what we call severe COPD. When we say severe, meaning leading to hospitalization. And 11% of patients with COPD died less than 90 days of hospitalization. But not only that, but it's well known that among patients who are hospitalized with severe exacerbation, 50% of these patients will die in about 4 years after hospitalization. So there's a very high risk of not only death during the hospitalization initially, but subsequently. And you can see from this slide or from the graph on the left, with every subsequent exacerbation, there is an increased risk of further exacerbation. So those patients can be identified, and those are the patients we need to target early so that we can prevent their need for hospital admission and recurrent exacerbation. It's interesting to know that our cardiology colleagues have really identified patients with risk of myocardial infarction, and they can prevent it. Why I'm saying this? Because actually the risk of dying from an acute exacerbation of COPD in the hospital is higher than the risk of dying from an acute myocardial infarction. But not only that, but now we have emerging evidence that with exacerbation can increase risk of cardiovascular mortality, increase incidence of thrombosis and acute myocardial infarction. There is a very good link between the heart and the lung, specifically in COPD. So what can we do for these patients? Obviously, there are non-pharmacologic approaches, and we can talk about that during the Q&A. We need to get them involved in smoking cessation, prevention, preventing infections, immunization, exercise, pulmonary rehab, very important. But when it comes to pharmacologic therapy, right now we're sort of boxed into bronchodilators, which are very important, and certainly in those patients with group B, those who are symptomatic, but not at high risk of exacerbation, maximizes the bronchodilator is what GOLD suggests we do. And in those with history of exacerbation, that's where an inhaled corticosteroids can be entertained, especially if patients have evidence of high blood eos in the baseline. And that's what at least Gold recent strategy has suggested. But Gold also suggested that these patients, after the initial treatment, should be followed. And if they continue to have symptoms, then you need to think if this is symptoms but no exacerbation, you may want to maximize the bronchodilation, maybe suggest that you check their inhaler technique and maybe change the delivery system, look at other comorbidities that may be contributing to the shortness of breath, particularly cardiac. But if they have repeated exacerbation, that's where inhaled corticosteroids and triple therapy has been shown to improve outcome in these patients. Not only that reduce exacerbation, but improve lung function and potentially, even though there were secondary endpoints in these large clinical trials, potentially they may prolong survival. There are other options in those patients. If they don't have high blood EOs, then roflumilast, the PDE4 inhibitors, or azithromycin can be used. Well, that's well and done, and we have more armamentarium now for treatment of COPD than before, but we need to keep in mind that even with triple therapy, these are important therapies for these patients. About 50% of patients continue to have exacerbation. This is from clinical trial, from the impact study on the left, the pie graph. And then this is a large study we were involved in where we looked at triple therapy versus LABA-LAMA and LABA-ICS in patients with high risk of exacerbation. Even in a clinical trial, many of these patients continue to have exacerbation during the year of the study. There are also retrospective and observational studies suggesting about a third of patients, even though on maximum therapy, continue to exacerbate. Therefore, exacerbations are important problem in this disease. Well, for many years, we thought this is a disease of airway obstruction, which is correct. We also now know it's a disease of airway inflammation, which is also correct. But also for many years, we thought this is a disease of neutrophilic inflammation, and T1 and T3 inflammation or type 3 inflammation are the most common type of inflammation in COPD. In fact, if you look down the airway of patients with COPD, if you do bronchial lavage or sputum induction, you'll see lots of neutrophils because this is driven by inflammatory cells and lymphocytes, including Th17, and cytokines like IL-17 and IL-8, and also TNF-alpha. This is actually the majority of COPD patients, what we call they have type 1 driven by Th1 cells or type 3 driven by Th17 cells, and usually driven by smoking. Sometimes microbial infections can also trigger this type of inflammation. But for many years, we thought this is it, that's it. And, this is the only type of inflammation. But we know now about 30 to 40% of patients with COPD have what we call type 2 inflammation. This is something that we know a lot about in asthma. And we're not talking about asthma COPD overlap. We're talking about patients with COPD who've never had asthma. If you look down their airway, they have actually inflammatory cascade that mimics what we see in asthma, driven here by different inflammatory cells, either the adaptive immune response through the Th2 cells, which can be driven by antigens, but other irritants, also smoke, of course, and microbes. But it can be driven by the innate immune system. Of course, the epithelial cytokines here are very important, IL-33, IL-25, TSLP. But importantly, downstream, this type of inflammation, what we call type 2 inflammation, is driven by cytokines that are, we know them in asthma, IL-4, IL-13, and IL-5, very important in the eosinophilic recruitment to the airway, but also in causing the structural changes, the mucus plugging, the remodeling that occurs in the airway. Indeed, these type 2 cytokines are obviously targeted now in asthma, and hopefully in the future will be targeted in COPD. But these are shown on the slides that each one of these cytokines have important effect in eosinophilic, what we call eosinophilic or type 2 COPD, including IL-5, which causes the recruitment of eosinophils to the airway, epithelial barrier dysfunction and fibrosis, mucus plugging and airway remodeling. IL-4 is important in the Th2 switching and IgE production. Some of these patients have actually allergic sensitization, even though they don't have asthma. IL-4 also is important in remodeling. and in emphysema formation. IL-13 is an important cytokine that causes mucus hypersecretion, airway remodeling, and airway hyperresponsiveness. So therefore, now in the year 2024, we know that the inflammation in COPD is not just restricted to the type 1, type 3 inflammation, but type 2 inflammation is important. So the question is, how important this type of COPD? It's 30 to 40%, so it's not the majority of COPD patients. But how, as a clinician, can I know if the patient has um, this type of inflammation? So now we are relying on biomarkers, and right now we don't have too many of them. I will share with you what we know about eosinophils, which tend to be a very important biomarker. Sputum eosinophils are more important, but they're very hard to get. So we now are dependent on blood eosinophil in a majority of time to tell us if patients with COPD has type 2 inflammation. Naturally, you have to rule out other causes for high blood eosinophil in these patients, such as parasitic infection or other allergies. But in general, blood EOs, if tested and if you have it on repeated basis, uh, being high, and what is high, and there is lots of discussion, what is a cutoff? In general, we use 300 cells per cubic liter in these patients to say the patient has high eosinophils or COPD with type 2 inflammation or COPD with eosinophilic inflammation. There is another biomarker, FeNO, which we know we use it a lot in asthma. The emergence of FeNO in COPD is still very slow. There are some data that suggest, and I'll show you one slide in a minute, that high FeNO may be associated with increased risk of exacerbation. But what do we know about blood eosinophils in COPD? How important are they? What do they tell us? Well, I can tell you up front, and I'll show you some data to support it, that blood EOs are not only prognostic, very important. The higher the EOs, the higher risk of exacerbation, but they're also predictive of response, particularly to inhaled corticosteroids, but in the future, maybe predictive of response to other treatments, including targeted therapies. And they may be pharmacodynamic. Their blood eosinophils may go down with treatment, like with steroids, oral steroids, with inhaled steroids. We'll talk about FeNO because FeNO has some good properties as well. So we have seen in many studies, these are a couple of them, one of them from Kaiser Permanente in California, where they actually looked at blood eosinophils. And again, it's hard to cut off, like it's not written in stone, but in general, as you see here in this study, the odds ratio or rate ratio of exacerbation correlated with the baseline eosinophils. And in general, above 300, increases the rate ratio of exacerbation. The higher blood EOs, the higher the risk of exacerbation. This other study looked at ED visit and hospitalization. We've seen these data also from clinical trials and also epidemiologic studies and observational studies. So yes, high blood EOs are prognostic biomarkers. The higher the EOs, the higher the risk of exacerbation. And this is a study actually that looked at readmission for in patients with high eosinophil versus patients with no eosinophil COPD. High eosinophil in the patient with COPD correlated with increased risk of readmission in this study, and this has been actually replicated in other epidemiologic studies as well. So why is it important to measure blood eosinophils? You know, for many years, we have measured blood EOs in asthma. We do that routinely in every patient with severe asthma. I measure IgE, blood EOs, FeNO, and of course, I do allergen-specific IgE if they have allergic triggers. In COPD now, we're measuring blood EOs in all these patients who come to us. Now, you have to be careful. Measuring blood EOs should be done not during hospitalization when they are on oral steroids, because that would beat the purpose. Their EOs would be very, very low. But when they are recovering, when they're off oral steroids, so there is no question that elevated blood eosinophils are associated with higher sputum and BAL. They correlate very well also with bronchial submucosal eosinophils. There is correlation, which I didn't show you, with greater decline in lung function and more pronounced airway remodeling. There is correlation between high blood EOs and increased severe and moderate exacerbation. And I will show you in a few minutes when we talk about precision therapy that actually high eosinophil predict response to oral steroids, but also inhaled corticosteroids. And they usually reflect the presence of underlying type 2 inflammation, which is occurring in about 30 to 40% of patients with COPD. What about FeNO? I don't have too many slides to show you about FeNO because we're still now gathering information. FeNO certainly, like in this small study, looked at exacerbation, and the higher the FeNO, and they used the cutoff of 20 parts per billion. As you know, in asthma, we use 25 parts per billion, but anything above 20 usually signifies high FeNO. But be careful, FeNO can be lowered by smoking. So if a patient has current smoker and is smoking heavily, their FeNO can be low, but their blood EOs may be high. So they still may have type 2 inflammation. But FeNO in general, if it is high, it suggests also type 2 inflammation, and it correlates with increased risk of exacerbation. So let's move to the third, but a very important component of my discussion. Where are we heading? Now that we know that there are some biomarkers, there are at least two types of COPD when it comes to the pathophysiology of the disease. We know that many patients, even though they were treated correctly and triple therapy has done wonders in these patients, but some patients continue to exacerbate. Where are we heading in COPD? From the pink puffer, blue bloater, to now knowing that it has multiple phenotypes and even multiple endotypes. This is where we were. We were looking at COPD in a one size fits all treatment. We treat them all as an umbrella with similar treatments. Right now, that's where we are. But I think where we're going to go using certain biomarkers, and I only showed you one, but there are several now: radiologic biomarker, radiomics, proteomics, and others, multiomics, to try to actually subdivide that group of patients so that we can appropriately use a first treatment A for that group, treatment B for that group. We're not there yet. We're getting there slowly but surely. Oncologists obviously know this by heart. Oncology, now we can test a receptor on a cancer cell and can have immune therapy for that type of cancer. And they've done wonders with precision medicine. We're not there yet, but we are trying. We know for sure that COPD has multiple phases. These are called phenotypes. The chronic bronchitis phenotype, those patients with chronic cough and sputum, they are at high risk of exacerbation. There's this pure emphysema phenotype by radiologically, by CT scan or doing lung volumes. You can diagnose emphysema, but most patients have a component of both. There's this eosinophilic COPD, which we've been talking about, characterized by high blood EOs and increased risk of exacerbation. There's this neutrophilic COPD. Although it says here increased blood neutrophils, many of these patients may not have increased blood neutrophils, but if you look at their airway, they have high neutrophils in the sputum, or if you do a BAL. And certainly these patients are not as responsive to inhaled corticosteroids, and they are the more common type of inflammatory phenotype in COPD. This is a very important group, the frequent exacerbator phenotype, 2 or more. These patients can be identified by taking a good history, and those are patients who are very high risk of future exacerbation. And of course, last but not the least, there is a group of patients that have both asthma and COPD, about 15 to 20% of patients. This is a bit tricky to identify, but certainly it does exist. And we try to shy away from using ACO as a term since Gold doesn't want us to use it. But this type of phenotype does exist, and we have to keep that in mind. Now, there's been some efforts to sort of treat patients with obstructive lung disease, treating them based on treatable traits, which can be pulmonary or extrapulmonary traits, basically diagnosing them with airway obstruction, looking at certain phenotypes, which may include biomarkers, may include symptoms, may include radiologic, and going and treating the traits. This is good for now because we don't have too many sort of biomarkers to subdivide the pie. But I think in the future, you're going to see this type of approach when it comes to treatment of these patients, identifying the endotype. And for that, we need more biomarkers. which we are working on, looking at either radiologic, biologic biomarkers. And of course, we can intervene by risk factor avoidance and affecting the exposome. And of course, genome. We have a huge undertaking in the U.S. We're part of it at Baylor, called the COPD gene study, and there's multiple groups around the world looking at genetics of COPD. We know alpha-1 antitrypsin is a very good endotype, but that's only 1% of all COPD patients. There are some genes now that have been identified to predict COPD in some smokers. It's not one gene, there are multiple loci, but we're not there yet. But I think genetics is very, very important to keep in mind. There are some now high risk, sort of polygenic risk score that we can calculate by checking a blood test for a patient and can identify patients who may go in, and if they smoke, they may be at higher risk of COPD. It's not there yet for the clinic use, but it's coming. So I think we have really shown that we can do a lot. Now, we talked about predictive ability of eosinophil. These are some examples from clinical trial. I'm a clinical trialist. We do clinical trials all the time. And what these show from different studies, they showed that the higher the blood eosinophils, and these are on the x-axis, the better effect of drugs containing inhaled corticosteroids comparing to a drug that has a long-acting. I'm sorry, this is switched. The colors are switched here. So this is the inhaled corticosteroids, and this is the LABA. So patients on LABA alone, the higher the eosinophil, the higher the exacerbation. But if they're treated with inhaled corticosteroids, actually the inhaled corticosteroids reduce exacerbation and sort of they flatten the line. Very similar from this large study, the study looking at triple therapy, which is now approved, and we have two products in the US with triple therapy, more to come. Again, if a patient was on the LABA-LAMA, only bronchodilator, the higher the eosinophil, the higher the exacerbation rate. On the other hand, if a patient has ICS, either ICS-LABA or ICS-LABA-LAMA, this is sort of flattened, suggesting that ICS, blood eosinophil, can predict response to eosinophils, can predict response to inhaled corticosteroid. This comes from a very old study called ISOLDI, where they looked at the effect of inhaled corticosteroid on lung function decline. And you can see those with high blood eosinophils, more than 2%, this is not an absolute number, had a better effect on the decline lung function with inhaled steroid than those who had lower blood eosinophil. So there is an effect on exacerbation reduction, but on lung function decline using blood eosinophil as sort of a predictor when it comes to treatment with inhaled corticosteroids. We also know that in this study where they actually withdrew inhaled steroids from patients who are on a LABA ICS, the Wisdom trial, and they wanted to see what happens. Well, in general, if the patient has less than 150 cells eosinophil, there actually was no increased risk of exacerbation when you withdraw the inhaled corticosteroid from the regimen. However, if they have high blood eosinophil at baseline, the higher the risk of exacerbation if you withdraw inhaled corticosteroids. There's quite a bit of evidence that linking the response to inhaled corticosteroids with baseline blood eosinophils in these patients. And then this is another one showing the pharmacodynamic effect of blood eosinophil, meaning does it go down? Of course, it goes down a lot if you give oral steroids. It actually, you wipe it out completely. But also this study, although very small, suggests that inhaled corticosteroid can reduce blood eosinophils in this small study. I usually don't follow that when inhaled corticosteroid. When I start, I use blood eosinophil to predict response, but I don't look at a decrease in eosinophils after I start inhaled corticosteroids. It's not really helpful clinically, at least in my practice. So why should we measure? Why should we bother measuring type 2 inflammation, particularly blood eosinophils? Well, I hope I convinced you that type 2 inflammation is common. Of course, it's not the most common type of inflammation, COPD. Occurs between 20 to 43% based on these references that you see on this slide. So that's substantial, about 30% of patients with COPD. There are some established biomarkers. Right now, it's blood EOs, and maybe FeNO will be emerging as well. There's a very good link between type 2 inflammation and clinical characteristics, but also risk of exacerbation and response to treatment. Um, we believe treating type 2 inflammation improves disease control. We have an example with inhaled corticosteroids, with triple therapy now. But still, I think addressing type 2 inflammation in the future is needed, and possibly targeted therapy may play a major role in this field. So in summary, what I tried to convey to you this evening is that we have a new look at this old disease. Certainly the pink puffer and the blue bloater look has to go. We have to think outside the box when it comes to COPD. It's a very, in fact, impactful disease. I've shared with you some numbers. Exacerbations continue to occur in these patients despite adequate therapy, underlining the need for new therapies and looking at other things. Why is it? Now we know that the COPD has multiple phenotypes, but we also know that it has multiple endotypes that drives the mechanism of the disease. We at least know that two types of inflammation occur. I shared with you what we know about type 2 inflammation, COPD, which is a very important problem, emerging problem that we can identify by measuring blood eosinophils. And hopefully in the future, we'll have more and more biomarkers to subdivide these patients even further so that we can appropriately select the appropriate treatment for the appropriate patient. With that, I'd like to again thank you for joining me. I will be standing by for any questions. Hopefully, we'll have any comments or questions. Just to emphasize, this is a disease state talk, so we're not really supposed to be discussing specific drugs. So I hope you don't, we can avoid discussing any disease state talk because of the nature of the program, but I'm very happy to discuss general questions about this talk in general about COPD. I always treasure your comments as well, and we'll turn it over now to the moderator, and then I'll look at the Q&A area in Zoom so that if I see if they have any, you have any questions for me. So there is I have two questions I can see, but Jason, did you want me to handle these?
Sure. Yeah, thank you so much. First of all, thanks for a great presentation. Again, Dr. Hanania. Yes, there are already some questions loaded up, and just wanted to let folks know, please send a question in now if you have it. Since it's Friday night, we'd love to get everyone off to their weekends when they can, but let's take some time now while we have Dr. Hanania. So the first question is, how do we reconcile the different spirometric definitions of airflow obstruction in diagnosing COPD? FEV1, FVC ratio, less than LNN versus less than 70%.
Yeah, thank you for the question. There was a pro and con debate at CHEST this year, which was in Boston, about specifically this. I wasn't part of it, but I attended it. I personally look at the lower limit of normal in my pulmonary lab, which probably is more accurate because, as you know, you can't go wrong by using 70% as a hard cutoff. You may underdiagnose or overdiagnose depending on the age group that you're dealing with. We use this as simple. Gold uses this 70% cutoff as a sort of simplify things. But we know that the FEV1 FVC is different in patients who are 80 years old versus somebody who is 40 years old. And so lower limit of normal may be better. We also look at post-bronchodilator ratio for both. In general, we try to maximize the bronchodilation and measure it after. So that's how we define COPD now. Having said that, we use lung function for diagnosis of COPD, but I want to leave you with a note that there is quite a bit of effort now, and we have a paper now in review, and there's some really good discussions that maybe spirometry alone for diagnosis COPD like this cutoff that we use. Right now, that's what we use. I don't want you to change your mind, but maybe this is not the way we diagnose COPD in the future. There is a group of patients with COPD, or at least patients who we don't call COPD, but are smokers. They have symptoms, but they have preserved ratio of FEV1 FVC. These patients are at high risk of exacerbation. Right now, we're not classify them in COPD. There's another group that have restriction, low FEV1, low FVC, and the ratio is normal, and that we call them PRISM, PRISM, preserved ratio in spirometry. So those patients in our COPD gene study, it's a substantial number of smokers. And studies now, longitudinal studies from around the world, have shown that these patients actually have progression of lung function decline. And some of them may end up with obstruction. Right now, we're not calling them COPD. There's another group where we get CT scan by lung cancer screening, and they have emphysema everywhere, but their airway function is still preserved and no obstruction. What do you call that? We don't call them COPD. There's another group that we do lung volumes and diffusion, and diffusion is very low, and yet we don't call them, COPD. So there's this entity called pre-COPD that includes those symptomatic patients, those with lung with CT scan changes, but also that physiologic small airway function using iOS device. Now it's becoming more popular. We have patients with small airway dysfunction, but not FEV1, FVC less than 0.7. What do you call these? So there's an entity called pre-COPD. There's actually some real discussion now. Maybe we should think twice in the future before limiting to the diagnosis to only those with the ratio. Sorry for the long answer to the question, but I appreciate it. I hope you'll keep thinking outside the box about diagnosing COPD in the year 2024 and beyond.
Thank you for that very thorough answer. Another question. What causes 30% of COPD to have Th2 inflammation while majority are Th1 and Th13 driven?
Yeah, very nice question. I wish I know the answer. I have no idea. Same question is, why would some patients have airway predominant chronic bronchitis type of COPD? That's the majority of patients, and some have emphysema. Why is it the destruction in the terminal lung and not in the airway? We don't know. I trust me, I'm very up to date in this. We don't know why some patients with COPD have type 1, type 3, and another group have type 2 inflammation. We know what drives these type of inflammation, but what initiate, we know initiation includes smoking and other exposure. But the reason some patients have type 2 versus type is not, as far as I know, nobody knows yet.
Thank you. I'll read this question and you can do your best to give us our answer.
Yes.
What is the most cost-effective treatment of the frequent exacerbator, rofumilast, for all Th1 and Th2 versus rofumilast for Th1 and presumably much more expensive biologic for Th2 and rofumilast for Th1 frequent exacerbators?
Well, thank you for the question. Obviously, without digging deep in specific drugs, as I mentioned, this is not supposed to be drug specific, but in general, it's an important question you're bringing up. So the frequent exacerbators, one of the very important issue first is looking at the back to basics, adherence. Very important before you jump up and add more drugs. And I agree with you. We don't want more expensive drugs if we can do with ones that are less expensive. Cost is a major issue in managing these patients. But we want to go back to square one. Patient is already on inhaled bronchodilators, triple therapy, or whatever. I want to make sure before I jump on, make sure they have they stop smoking and exercise and all the other stuff that you need to emphasize every visit, but also adherence. Are they taking it? Are they using the inhaler correctly? If they are and they're still exacerbating, certainly PDE4 inhibitor like rofumilast has a role in chronic bronchitic patients, particularly those hospitalized patients. Azithromycin, as I showed you, has a role in some of these frequent exacerbation patients, particularly those with ex-smokers. You have to be careful with these drugs because some of these have GI side effects, what is erythromycin, cardiovascular, hearing side effects. And now we have nebulized PD3, PD4 inhibitor approved in the United States this year, actually, which may work in some of these patients in nebulization to target PD3, PD4. We're still not there with biologics. You know, we know one biologic was just approved, more to come. There are several in the pipelines. We're studying them all. I think in the appropriate population, there may be a role for biologic, obviously, like they are in asthma, but these are small selected patients with who are identified based on the biomarkers. I think right now, that's why GOLD, they change their algorithm every year. So next month, well, this month actually, November, will be in, I'm not part of GOLD, but I'm giving a talk there in November. They will probably update their algorithm. They may be adding more and more of these new drugs coming out. And again, GOLD is not written in stone. They're not guidelines, they're suggestions. But of course, you have to look at the patient as a whole, and not every patient is the same like others. So you have to look at the whole picture before you decide which treatment you're picking.
Thank you so much for the great answer. Next question. How does the COPD asthma overlap picture fit into the analysis and treatment protocols for type 2 inflammation and COPD?
Yeah, thank you for the question. Obviously, asthma COPD overlap patients have type 2 inflammation because they have asthma, which is mostly 70% of asthmatic is driven by type 2 inflammation. But we're talking, and that's well and good. But when we talk about COPD with type 2 inflammation, we're talking about patients who never had asthma as a child, never, don't have any asthma in their in their diagnosis at least. Now, can we miss some patients with both? Yes, sure. It's not a hard cut off. It's not black and white. But in general, somebody who developed symptoms after 20-pack years smoking, has fixed airway obstruction, and has high ears on his peripheral blood, that looks like COPD. Somebody with asthma as a child and then smoked for 20 years, and now he has fixed airway obstruction and has ears, and most likely this is an asthma COPD or has allergic rhinitis and other allergic phenotypes. So as a clinician, it's sometimes very hard to differentiate, but most of the time, if you spend some more time, you can. Now, somebody was telling me, does it matter? Well, it does from the prognosis point of view. Somebody with asthma, they need to not be labeled COPD if they don't have it. But when it comes to treatment, as you see from my slide on treatable traits, sometimes, if they have asthma COPD overlap and have type 2 inflammation, and then have COPD with type 2 inflammation, and you have drugs that work in both, it may not, clinically, may not matter. It may, you treat them targeting the type 2 inflammation, whether inhaled corticosteroids, which is the option right now we have early on. So with asthma COPD overlap, compared to COPD alone, you have to treat them for asthma. You have to use inhaled corticosteroids early and not wait until they exacerbate, like we do with usual COPD.
Thank you again for another thorough answer.
You're welcome.
We'll give our last call for any final questions before we let Dr. Hanania go this evening. We'll going once, going twice. All right. Well, if there are no other questions for this evening, I see some thank yous coming through, and I couldn't agree more.
No, it's been a pleasure. Thank you so much for inviting me. I'm very excited. I've been in practice 30 years, and when I moved to Houston from Toronto, where I trained, we had only limited options for these patients, and now we have more and more. And we're understanding the disease more, so it's really exciting. I don't know how excited you guys are, but I'm very excited that this is a disease now we have put on the shelf for many years, and now we sort of bring it back because it's haunting us, because we want to get better outcomes. You know, we're not there yet. I can't admit we've solved every problem, but I think we know a lot more about COPD now than we used to even 10 years ago, and more to come. So I think if you're working in this area, you're into a long, you're going to see more and more just looking at our clinical trials, we're involved in so many new targeted therapies that we're studying, and you'll see more and more. Hopefully, some of these will end up being approved. We don't know, but at least we are thinking now outside the box when it comes to this COPD.
Well, thank you again, Dr. Hanania. We couldn't agree more with everything you said.
Thank you so much
Thank
for
you.
inviting me. You have a great evening, a great weekend.
Yeah, thank you again to GSK for their support of our Friday evening educational webinars. We really sincerely appreciate the opportunity to have these educational partnerships and open dialogue and opportunity to ask questions and talk about these things. This is a great opportunity to learn together, and we hope to see you all in a future CTS Friday evening educational webinar.
Thank you. Bye.
Thanks again, everyone.